Hello, and welcome to this episode of In Discussion With from PharmacyUpdateOnline. Today I'm talking to John Donoghue about the management of insomnia and how this might be transformed by the use of dual orexin receptor antagonists, DORAs. Please, could you start by introducing yourself?
My name is John Donoghue, and I am a consultant mental health pharmacist, and I work in a freelance capacity.
And can you give us a brief overview of your current role, what your job involves?
I run a very small company called Medicines in Mental Health Limited, and essentially I do three things. The first is to provide continuing education related to the treatment of severe mental illness. My key interest is schizophrenia, but I also cover major depression and bipolar disorder. And the medical education is available to psychiatrists, pharmacists, mental health nurses, psychologists occasionally turn up as well. And I've also been involved in social worker training because, of course, social workers are closely involved in mental health care. So that's the first aspect of what I do. The second aspect of what I do is research. My research interest is pharmacoepidemiology. I was an early adopter of big data, and I've been involved in what I regarded as landmark studies, particularly in using big data to follow outcomes in major depression. The third aspect of what I do is to provide consultancy. I provide consultancy mostly to the pharmaceutical industry, but also occasionally to the National Health Service.
Well, today I want to explore the use of Daridorexant, which looks like a completely different class of drug for insomnia. But first, I need you to give us a bit of background. What is insomnia? Is it more than just a few sleepless nights because you're worried about something?
It most certainly is. Um, Insomnia is often underestimated. It's underestimated by the general public and it's underestimated by health professionals as well. And I think part of the reason why it's underestimated is because we view it as part of the natural order of things. Everybody, from time to time, experiences insomnia. What we don't perhaps appreciate is the effect that chronic or long-term insomnia can have on people's lives because it affects not just their emotional well-being, it affects both their mental health and has physical health consequences as well. Insomnia essentially has three components. The first component is difficulty in getting to sleep. The second component is difficulty staying asleep. And in fact, most people with chronic insomnia experience both of those factors. The second factor is it must be associated with significant consequences the next day. Uh, if you're going to have a diagnosis of clinically relevant insomnia, then essentially you have to feel awful the next day. The third element is it can't be a consequence of some environmental influence. So if the water company decides that they're going to dig up the road outside your bedroom window and they have a steam hammer going day and night and you can't get to sleep, that's not insomnia. That's an external factor that is preventing you from getting to sleep. So insomnia is something intrinsic that is happening to you as an individual. And essentially, we divide insomnia into short term and long term. So short term insomnia persists for less than 3 months. And there's really nothing too much to worry about that. It will remit spontaneously in the vast majority of people. And short term, occasional insomnia is very common. It affects as much as half of the adult population at any one time. And that's perhaps one of the reasons why we underestimate how important it is. Chronic insomnia has to persist for more than 3 months and must happen at least 3 times a week. And chronic insomnia also is remarkably common. And various studies have found that it affects between 5 to 10% of the adult population. The 10% figure is typically found in a GP's surgery on a Monday morning. And the reason why that happens is because chronic insomnia has a strong association with chronic illness. So illnesses where there is perhaps, for example, physical pain or disability, difficulty in breathing, those sorts of conditions, strong association with chronic insomnia. Psychiatric illness, major depression has a strong association with chronic insomnia. And as we get older, we are more likely to experience insomnia, largely because as we age, we produce less of the sleep hormone melatonin. And if we produce less melatonin, we find it more difficult to get to sleep.
Very interesting. Insomnia, as you've mentioned, has both emotional and physical effects. Let's talk first about that. Can you give us some examples?
There's a very interesting study in the literature on insomnia where people with chronic insomnia were asked to describe the effect that it had on their lives. So this is very much in emotional rather than mental health terms, but in emotional terms. And they described three key elements. The first was they felt that it caused them to struggle, and they had no option other than to try and struggle through. So the day after insomnia was a struggle, but they just had to get on with it. The second aspect was feeling of isolation. They felt that they were on their own having to deal with this. And this feeling of isolation was made worse if significant others in their lives, so family members or work colleagues, for example, friends, if those people didn't take it seriously. And the same was true if health professionals didn't take it seriously. And the third element that came through very strongly was that they felt they had to put their life aspirations aside because the struggle that was involved in dealing with insomnia and the isolation that they felt in having to deal with insomnia meant that they really couldn't think about planning for the future. So they were living very much in the moment, struggling through the moment, and their aspirations were put on hold. So those were the emotional aspects of the consequences of insomnia. But to give you just a few examples of the impact that insomnia can have on physical health. So if we talk about having less than 5 hours sleep at night, if you have less than 5 hours of sleep at night, your risk of type 2 diabetes trebles. If you sleep for less than 5 hours a night, your risk of hypertension increases fivefold. If you sleep less than 6 hours a night, your risk of impaired cognitive functioning more than doubles. And your risk of vascular impairments of cognitive functioning, so the kind of mini strokes that lead to vascular dementia, again, more than doubles. Now, I was involved some years ago in a study in major depression, and we were interested in examining the impact that insomnia in major depression had on outcomes. And we were using the clinical practice research dataset. And so we had data on thousands of patients, and we compared patients with insomnia with patients who did not have insomnia, but all with a diagnosis of major depression. And the outcomes we were able to look at were the number of GP appointments that people used, medicines that they were prescribed, both for insomnia, for psychiatric conditions, but also for physical health conditions, the number of outpatient psychiatric referrals that they had, the number of inpatient psychiatric admissions that they had, and also attempted suicide. For every outcome, insomnia made it worse. So people with major depression with insomnia needed more GP appointments. They consumed more medicines across the board. They had more psychiatric outpatient appointments. They had more psychiatric inpatient admissions, and there were more attempted suicides. And this feature of insomnia in making outcomes worse and making good outcomes more difficult to obtain goes across the board into physical health. For example, the management of chronic pain, hypertension, diabetes, and other forms of cardiovascular disease.
Mm. So, insomnia is clearly not a trivial condition. It occurs to me on the basis of what you've said, is there an association between insomnia and mortality?
There most certainly is. A large study conducted by the RAND Corporation in Europe compared outcomes in people sleeping less than 6 hours a day with outcomes in people who slept from between 7 to 9 hours a day, a night. Now, that isn't a large difference, but even that small difference is associated with a 13% increase in mortality risk. That's a big increase. Now, a big part of that was accidents, because clearly insomnia is going to be associated with accidents if people don't actually take heed of the fact that they know they're impaired the next day. But it's not just accidents. There's increased mortality in stroke, in cardiovascular disease generally, but also from cancer. So insomnia absolutely is not a trivial condition.
Mm. Let's talk now about the clinical management of insomnia. Are there guidelines? And if so, what do they say?
There are guidelines. The most relevant is perhaps the NICE clinical knowledge summary that was published earlier this year. And the NICE clinical knowledge summary recommends cognitive behavioral therapy for insomnia as the first line treatment for adults. The recommendation, which I don't think is a terribly helpful one, is to avoid long-term pharmacotherapy. And that seems to me to be a little bit counterproductive when you're talking about a condition that in itself is chronic. If symptoms are severe, or if there's a patient who has an acute exacerbation of worsening insomnia, then a short-term Z drug like zopiclone could be considered. Or if the patient is aged over the age of 55, prolonged release melatonin. Now, that recommendation relating to the age being over 55 is simply an artifact of clinical trial designs. Clinical trials were largely conducted in patients over the age of 55 because that's when we produce less melatonin. There is also a recommendation to offer patients this new treatment, Daridorexant, providing that patients meet the criteria for chronic insomnia. So difficulty in getting to sleep or maintaining sleep that is happening at least 3 times a week and has been going on for at least 3 months. And we'll perhaps talk a little bit more about Daridorexant later on. But in a kind of piece of advice to community pharmacists, if a patient meets the criteria for chronic insomnia disorder, they should not offer over-the-counter treatments. They should refer to the patient's GP, or of course, if they're a prescribing pharmacist, they may decide to offer treatment themselves.
We'll come back to several of those points later, but can we briefly talk about the non-drug options for insomnia? You mentioned cognitive behavioral therapy, and I've seen there are a couple of apps, Sleepio and Sleepstation. Can you comment?
Absolutely. Cognitive behavioral therapy has been the subject of randomized controlled trials, and it has been shown to be effective. There is a systematic review that compares um, cognitive behavioral therapy with benzodiazepines. Um, and the results I thought were quite interesting. In the short term, cognitive behavioral therapy for insomnia was not as effective as benzodiazepines. Now, I don't think that's a surprise because we know that benzodiazepines work quickly and cognitive behavioral therapy, by its very nature, takes a while before it starts to work. So that's not a surprise. In the longer term, cognitive behavioral therapy for insomnia was better than benzodiazepines. And again, I don't think that's a surprise because we know cognitive behavioral therapy for insomnia is effective, and we shouldn't be using benzodiazepines in the long term anyway. But one of the things that the systematic review did note was that the quality of evidence was poor. And that does give me a little bit of pause for thought, as it were, when thinking about, well, which treatment should we be offering as the first choice treatment? And ideally, of course, what we need is a direct head-to-head comparison in a randomized controlled trial of cognitive behavioral therapy and whatever drug treatment is deemed to be appropriate. And those studies are largely lacking.
I wonder if you could clarify for those of us who are not familiar with this clinical field, what does cognitive behavioral therapy involve?
Ah, good question. Um, the CBT for insomnia has four key components. The first of them is sleep restriction. So you don't let people sleep during the day because napping during the day means you're not going to sleep well at night. The second is what they call stimulus control. So avoiding things like screens in the evening because they again can affect your ability to get to sleep. The third is a fairly strict application of sleep hygiene, so getting into good habits for getting to sleep. And then the final aspect is the kind of element of cognitive therapy, which essentially is helping patients to learn about the behaviors that lead to poor sleep and showing them how they can challenge those behaviors that lead to poor sleep. Now, I'm not a cognitive behavioral therapist, so it's not really for me to tell people how to do it. But those are the essential four components, as at least as I understand it. When it comes to the other things you asked about, Sleepio and Sleepstation, um, they are essentially online modules of cognitive behavioral therapy for insomnia. Sleepio has been reviewed by NICE, and NICE have approved it for use in the NHS in England. As far as I'm aware, SleepStation has not been reviewed by NICE. Um, I did have a look at their website at one point, and although the website claims that they have good evidence for its effectiveness, all the evidence that they cite on their website is from individual endorsements. So I'm not aware of any controlled trials of SleepStation. I may be wrong on that, but I couldn't find any evidence for that. But Sleepio definitely has been reviewed by NICE and recommended by NICE.
Mm. Let's turn now to medicines used to treat insomnia. And could you give us a brief primer on the available options, the advantages and disadvantages? Perhaps we could start with the benzodiazepines and the Z drugs. Do they have a place in the management of insomnia?
If they do have a place, I think it's largely in the very short term. Um, both benzodiazepines and Z drugs um, have a quite similar pharmacology in that they're both GABAergic. Essentially, what that means is that they promote the activity of GABA in the, sorry, gamma aminobutyric acid, for those who don't know GABA, um, within the brain. Now, GABA is actually the most common neurotransmitter in the brain, and it's essentially the inhibitory neurotransmitter. So GABA is there to close down excitatory pathways in the brain, um, to help keep us calm and to help us to get to sleep. So what GABA does is it reduces neuronal firing in, for example, dopaminergic pathways, histaminergic pathways, and other excitatory pathways. And what benzodiazepines and Z drugs do is they connect with a sub aspect of the GABA receptor. So a kind of element of the GABA receptor. And what they do then is the GABA receptor becomes more receptive to the endogenous GABA. So it's essentially, if you like, dialing up GABA rather than having a direct effect on the GABA receptor itself. So they're not agonists at the GABA receptor, they're modulating the GABA receptor. So benzodiazepines are non-selective. So benzodiazepines will promote the action of GABA in pathways related to sleep. So they do induce sleep, but also in pathways related to anxiety and pathways related to memory. So they are also, in addition to inducing sleep, they're anxiolytic, but they also have an amnesic effect, which is quite common with benzodiazepines, particularly short-term memory. Now, Z drugs are slightly more selective. So they induce sleep. They do also have the amnesic effect, but they don't have the anxiolytic effect. Now, that in itself is perhaps not enough to distinguish between the two classes of drugs. The biggest difference really is in drug half-lives. So Z drugs, generally speaking, have shorter drug half-lives. So they help the patient to get off to sleep, but they're not there in the same concentration the next morning. So you don't have the next day hangover effects. And that was thought that it would give a significant advantage over benzos in terms of A, the next day hangover effects, but also the development of problems with dependency. It hasn't quite worked out that way. And NICE conducted a technology appraisal review of Z drugs. And in their technology appraisal review, they said there was no compelling evidence of a clinically useful advantage with Z drugs compared with benzodiazepines. And they recommended that short-acting benzodiazepines should continue to be the treatments of choice. But it's worth pointing out that a shorter-acting benzodiazepine, commonly used as hypnotic, which of course is temazepam, has a half-life of between 10 to 20 hours. So if a person takes 20 milligrams of temazepam at bedtime, the next morning they've still got 10 milligrams of it left. So if they then set out to drive a car, for example, they're driving with 10 milligrams of temazepam in their bloodstream. And here's one of the things that pharmacists must advise patients. Not be careful when you're driving, but simply do not drive. Do not operate dangerous machinery of any kind, because even the short-acting benzos have these significant hangover effects.
That's a very important message and totally consistent with what is seen in practice. I've just got one question. Is there a case for using Eszopiclone?
Yes, I think there is. There is evidence that Eszopiclone is different. And of course, as part of its license, unlike zolpidem and zopiclone, it is available for longer term use. And that the product license says it can be used for up to 6 months. So I think there is a case for using Eszopiclone, and certainly in preference to zopiclone or zolpidem.
And what's the difference between zopiclone and Eszopiclone?
I wish I knew.
Oh, right.
Well, the difference is just that Eszopiclone is an enantiomer of zopiclone. So it's the active enantiomer of zopiclone, but for some reason it appears to be less prone to causing dependency.
Mm. You mentioned melatonin earlier. Where does melatonin fit and how does it work?
Melatonin, I think, is a very interesting compound. It's often called the sleep hormone. Uh, Melatonin is produced in the pineal gland, which is situated within the structure of the brain. It sits at the top of the brain stem, but it's not part of the brain. It's actually outside the brain. And the pineal gland synthesizes melatonin on demand. So it doesn't store it, but it synthesizes it when required. And what stimulates the demand is the onset of darkness. So as it gets dark, the pineal gland synthesizes melatonin and releases it into the brain. And it is transported across the brain to a small structure within the brain called the suprachiasmatic nucleus, which is the body clock. And in the body clock, it essentially does two things. The first is it gives a circadian signal to the suprachiasmatic nucleus, so a phase shifting signal, because hours of daylight vary throughout the year, so the hours of darkness vary. So we have a small adjustment in sleep onset literally every day of the year. The second thing melatonin does is it sends an inhibitory signal to excitatory pathways in the brain. So to glutamate pathways, dopamine, histamine, and so on. Now, the signal that melatonin sends is not as strong as is produced by GABA. So whereas you can think of GABA as more or less an off switch, melatonin is more like a dimmer switch. So melatonin reduces neuronal firing, but it doesn't virtually stop it in the way that GABA does. The question is, how effective is melatonin? Um, in chronic insomnia, the answer is not very. And there have been a number of meta-analyses of clinical studies. The studies tend to be rather small, but compared with placebo, melatonin reduces the time it takes to get to sleep by maybe 4 or 5 minutes. Now that's a statistically significantly, statistically significant result, but is it clinically important? Probably not. There is also an increase in sleep duration of approximately 13 minutes. And again, that is statistically significant, but is it clinically important? Probably not. So in chronic insomnia, melatonin is not as helpful as we might hope. The NICE guideline specifies prolonged release melatonin. The reason for prolonged release is that melatonin has a very short half-life, 30 to 40 minutes. So literally, as soon as melatonin is released, it's on its way out. And that's why the pineal gland it synthesizes melatonin throughout the night. And then with the onset of daybreak, it stops synthesizing melatonin. And then, of course, it's very quickly cleared.
So, would you support melatonin being made available as an over-the-counter treatment?
I absolutely would. Yeah, I think it's ludicrous that as an over-the-counter treatment, we're offering people antihistamines, which are far more toxic than we think they are, but we're not offering melatonin. And particularly for sleep problems that are caused by phase shifting, like jet lag, melatonin can be quite useful for that. But instead, we offer people an antihistamine instead. Doesn't make sense to me.
Mm. Of course, in the US and in Australia, melatonin can already be bought over the counter as a food supplement. Is it really not available here in the UK?
Not as far as I'm aware. No, I'm sure it's a prescription only medicine.
You've touched on antihistamines, and I know a number of other classes of drug are used for insomnia. I'm thinking of antihistamines, antidepressants, antipsychotics. Would you like to comment on those?
Yes. I think we need to be much more careful about over-the-counter antihistamines. than we generally are. We tend to think of these as fairly benign drugs. If you look in the BNF, you'll see a long list of side effects, but there's no real context given about the side effects for antihistamines. We really need to think about which side effects are common and which side effects are actually likely to cause problems. But typically, antihistamines that are freely, diphenhydramine, for example, which is in the sleep medicine Nytol. Diphenhydramine can cause ataxia, blurred vision, constipation, dizziness, all sorts of, and these are common side effects. You may be aware that in the United States, there is a warning on the FDA website about diphenhydramine. In the United States, there is a teenage phenomenon called the Benadryl Challenge, which has been promoted by TikTok. And in the Benadryl Challenge, teenagers are challenged to drink a bottle of Benadryl in one go. And there have been numerous admissions to emergency rooms and also a number of deaths. So diphenhydramine and drugs like promethazine are not the benign drugs that we think they are, and they do need to be used cautiously, and patients should be warned about, particularly the danger involved with driving after they've been taking them. It's also quite common for antipsychotics and antidepressants to be used to induce sleep. I personally take quite a dim view of this, largely because these are very potent medicines. They do have quite significant adverse effect profiles, and they do need to be used cautiously. They should be used for their primary indications. Antipsychotics should be used to treat psychosis, which is a very, serious condition. So using an antipsychotic like quetiapine to induce sleep, for example, in my view, is really not a good idea. And the same goes for antidepressants. You think about amitriptyline being used. It's extraordinarily cardiotoxic. Mirtazapine is also used, and that has significant problems, for example, with weight gain and some anticholinergic effects. So generally speaking, I would try and avoid antipsychotics and antidepressants as hypnotics.
That has brought us very nicely to dual orexin receptor antagonists, DORAs. So, what is orexin and what role does it play in chronic insomnia?
Orexin is a relatively recently discovered neurotransmitter. It's an excitatory neurotransmitter that promotes wakefulness. And it was only discovered at the end of the 1990s by researchers who were trying to understand narcolepsy. And what they found was that people with narcolepsy had difficulty in producing this neurotransmitter, orexin. So they didn't have that excitatory wakefulness signal going on in their brain. To understand orexin, we need to think about the circadian sleep-wake cycle. Through the hours of daylight, a compound accumulates in the brain, adenosine. And the buildup of adenosine in the brain contributes to sleep pressure. So if you're feeling sleepy during the afternoon, which happens quite frequently to many people, that's because of the buildup of adenosine in your brain. Now, with the onset of darkness, the pineal gland starts to release melatonin. And the combination of melatonin and adenosine produces a peak in sleep pressure. And if you don't have insomnia, you fall asleep quite naturally. And we have our deepest sleep a few hours after that. Now, over the course of sleep, the brain clears the adenosine. So the next morning we start with a clean sheet of paper, as it were. With the onset of daylight, the pineal gland stops producing melatonin, and because it's short half-life, it's quickly cleared. But the absence of melatonin by itself is not enough to wake us up. We need something to kickstart us into wakefulness, and that's something that kickstarts us is orexin. And as melatonin is synthesized in response to the onset of darkness, orexin is released in response to the onset of daylight. So we have orexin released, it feeds into excitatory pathways, and it gives us this wake signal. So shortly after orexin is released, we wake up and we have peak alertness a couple of hours later, usually early to mid-morning. So that's the role that orexin plays within the circadian sleep-wake cycle. And current thinking about chronic insomnia is that it is a disorder of orexin overactivity. So orexin is being released inappropriately during the hours of darkness. So it's giving us a wake signal when we should be sleeping. So that is the current thinking about the pathophysiology behind the role that orexin plays and the pathophysiology of insomnia. And that's why things like simple sleep hygiene measures are not going to help people with chronic insomnia, where the insomnia is actually being caused by the inappropriate release of orexin. The sleep hygiene won't stop that release of orexin. So, sorry, if we move on to what a DORA does. So DORA is a dual orexin receptor antagonist. So a DORA is an orexin blocker. And the nerve pathways that are associated with orexin originate in the hypothalamus. And if we imagine a nerve terminal of one of these orexin neurons, there are two subtypes of orexin receptor called orexin 1 and orexin 2. And they have different functions. The orexin 1 receptor goes to pathways in the brain associated with motivation and reward. Because as you'll know yourself, I'm sure, you wake up in the morning and your first thought is, I can't be bothered getting out of bed. So you need that secondary motivation reward signal to tell you, no, it's worth getting out of bed. You know, they've got the day ahead to look forward to. So that's the orexin 1 receptor. The orexin 2 receptor is the wake signal. So we need both of these receptors to be activated. But because we've got two receptor subtypes, we also have two types of orexin. And these are called orexin A and orexin B. So the orexin 1 receptor, which is the motivation reward receptor, is selective for orexin A. But the orexin 2 receptor, which is the wake signal receptor, will accept both orexin A and orexin B. So the wake signal dominates. So you get that wake signal as the stronger signal, and then the motivational signal comes after. But most people need both of those. So DORA, quite simply, blocks both of those receptors. So it's an orexin A because it's a dual receptor antagonist. So it blocks both orexin A and orexin B, and it suppresses that wake signal. So if we have inappropriate orexin release during the hours of darkness when we want to be asleep, taking a DORA at bedtime blocks that wake signal. And it doesn't just block the wake signal, it also blocks the motivation reward signal as well. The important thing to note from this is that unlike a hypnotic that promotes GABA, which closes down all of the excitatory pathways in the brain, DORA doesn't close down those pathways. All it does is prevent the wake signal from reaching those pathways. So the normal background activity that those pathways have during the hours of sleep is maintained. So DORAs are not hypnotics in the way that benzodiazepines and Z drugs are. They're not inducing sleep. They're merely preventing you from having the wake signal at an inappropriate time.
Hmm, this is very interesting. Now, I understand that Daridorexant, which is a DORA, is available in the UK. Has it been approved by NICE?
It has indeed. NICE published a technology appraisal guidance document over 2 years ago now. It was October 2023. And NICE have recommended Daridorexant for the treatment of insomnia in adults. Patients have to meet criteria for chronic insomnia disorder. So they have to have difficulty in getting to sleep or difficulty maintaining sleep. They have to have the adverse daytime consequences, and it has to have gone on for at least 3 nights a week for longer than 3 months. So if they meet those criteria, then Daridorexant can be prescribed. NICE has recommended it should be a second-line treatment following CBTI. So if CBTI has been tried but not worked, then Daridorexant can be prescribed. But NICE have also said that if CBTI is not available in a particular location, Daridorexant can then be prescribed first line. Or if the patient refuses CBTI, then again, Daridorexant can be used first line. My personal view is if you've got a waiting list of over a year for CBTI, that is tantamount to saying that it's not available. And in which case, we should not be keeping patients waiting. We should then offer Daridorexant as a first line treatment. Now, the NICE recommendation does come with a number of caveats. The first caveat is that NICE says that treatment should be as short as possible. That's not a caveat I agree with. I think what they should be saying is treatment should be as long as is necessary. Because we're dealing with a chronic disorder that has significant consequences, both for physical and mental health. There is good advice about regular assessment of outcome. The NICE recommendation is that treatment should be assessed within 3 months. I think that's good advice. Stop if there's lack of response. Well, that seems obvious. And if treatment is to be continued beyond 3 months, then it should continue to be assessed at regular intervals. And as we'll see when we discuss the clinical trials, the regular intervals, probably every 3 months, seems a reasonable time interval for assessing. So with those caveats in mind, Daridorexant is recommended by NICE and is supposed to be available across England.
You tell a very compelling story. So my next logical question is this supported by trial evidence?
It is indeed, yes. There are two large randomized placebo-controlled trials of Daridorexant in patients with chronic insomnia. Both are reported in the same publication, which was Lancet Neurology. And the reason why they were both published in the same publication was because the trials were essentially identical. The only difference between the trials were the doses of Daridorexant that were used. Now, to kind of cut a long story short, there were two important features came out of the trials. First of which was that the 50 milligram dose is the dose that should be used for most patients. In the trials, they used 10, 25, and 50 milligrams. The 10 milligram dose is not licensed in the UK. 25 milligram dose can be used in some circumstances, but for the vast majority of patients, the 50 milligram dose was superior. And it was superior on all outcome measures. So that's the recommended dose. The second feature of the trials is Daridorexant does not appear to be suitable as an acute treatment. what you see is some effect after 1 month, a bigger effect after 3 months, and a bigger effect again after 6 months. So there seems to be a cumulative effect. So that's important when considering advice that you might give to a patient. To say to a patient that this may work quickly, but it may not. And your initial trial of treatment really should be for 3 months in order to make sure the patient does have the opportunity at least to get the full effect of daridorexant. Now, in terms of outcomes with daridorexant, with the 50 milligram dose, after 3 months of treatment in a two randomized placebo-controlled trials, patients at 3 months were getting approximately an hour extra sleep at night. And this was a result of getting to sleep approximately 30 minutes faster and then not waking up during the night for 30 minutes less. So overall, an hour extra sleep. Now, those findings were confirmed with polysomnography. So those were objective findings. But there was also a patient reported outcome, which was how long did you stay asleep for during the night? And patients reported staying asleep for approximately an extra hour. So very close relationship between the objective polysomnography findings. There's another important outcome measure from this study, which was daytime sleepiness the following day. Now, this is important from two aspects. First of all, daytime sleepiness as a result of insomnia is important because that can be a source of accidents. But it's also important as an outcome measure because we know with benzodiazepines you often get hangover effects. So this was another patient-reported outcome measure, but was measured using a formal questionnaire that patients were asked to complete. And with the formal questionnaire, patients need to show an improvement in daytime sleepiness of at least 4 points over and above placebo for it to be considered clinically relevant. And at the 3 month mark, with the 50 milligram dose, the improvement was nearly 6 points. So we have significant improvement in alertness the following day with daridorexant, which in itself is another important outcome measure. One of the downsides of blocking receptors in the brain is it's often associated with a wide range of difficult side effects. If you imagine blocking dopamine receptors, as we do with antipsychotics, huge range of unpleasant side effects. Blocking histamine receptors, blocking alpha receptors in the brain, blocking muscarinic receptors, wide range of side effects. So one would anticipate that blocking the orexin receptors, and of course, don't forget we're blocking both of them, the 1 and 2 receptor, you would expect, again, a wide range of side effects. If you look in the BNF or the datasheet for orexin, you'll see a long list of side effects reported. However, as is usual with the BNF, there is no context given. And if you look at the statistics related to this long list of side effects, what you find is that there's only one side effect that occurred statistically significantly more frequently than with placebo. And that one side effect was fatigue. That side effect was reported by 4% of patients treated with daridorexant compared with 1% on placebo. Now, if you calculate the number needs to harm for that side effect, the number needs to harm is 33. So what that means is 33 patients have to be treated with daridorexant to have one extra case of that side effect occurring than would have occurred with placebo. So that is far from being a common side effect. And in fact, it's going to be quite rare that it's observed in clinical practice. But that was the only side effect that occurred more frequently than with placebo. And that's an extraordinary finding because we are blocking receptors in the brain. And we have one single side effect that occurred in one in, is it 25 patients? Yes, one in 25 patients. Extraordinary. So we have, with Daridorexant, an effective treatment for insomnia with a remarkably benign side effect profile, at least in the short term. And by the short term here, I'm saying at 3 months. That's great, but there are still unanswered questions from that. If you think about using benzodiazepines or Z drugs, the recommendation and correct recommendation is that they should not be used long term. Really, they should not be used for longer than 2 weeks. And for very good reasons. So there are questions about whether daridorexant should continue to be used beyond the 3-month mark. And so there is now a long-term study, and it was designed as an extension study to the 3-month shorter term study. So patients who completed the 3-month study were asked if they would like to continue into a long-term study so that it would last for up to a year. Those patients who were already taking daridorexant stayed on the same dose as before. Those patients who were previously on placebo were re-randomized to either continue with placebo or now to take daridorexant 25 milligrams. Now, the key outcome measures here were related to side effects, but also to the possibility of a withdrawal syndrome and perhaps dependency. So the key outcomes were, did any new side effects emerge in longer term treatment? Did any of the original side effects get worse during the longer term treatment? And at the end of treatment, when daridorexant was withdrawn, were there any withdrawal effects on discontinuation? So those are the key outcomes for this study. But there were also exploratory outcomes, which were total sleep time and daytime functioning. Well, let's turn first to the primary outcomes of worsening or increase in side effects. And again, the study has a long list of side effects and no statistical analysis of the side effects. So what I took upon myself to do was to calculate the number needed to harm for the 50 milligram dose, because that's the dose that most patients will receive, compared with placebo. And for every single side effect, the number needs to harm showed that it was no different from placebo. So we have placebo level side effects for every single side effect in the long term. And again, that is absolutely extraordinary finding. I can't think of a drug that over a 12-month period has a side effect profile that is no different from placebo. I mean, with my experience in psychiatry, absolutely none. I don't know if you know of any in physical medicine. At the end of a year, daridorexant was withdrawn, and patients were specifically monitored for withdrawal symptoms, and there was no evidence of any withdrawal-related effects at the end of treatment. So again, remarkable, because with other medicines that block receptors in the central nervous system, with antipsychotics, with antihistamines, with drugs that have antimuscarinic effects, we often see rebound withdrawal effects when the drug is stopped. So not to have withdrawal effects with daridorexant, again, is a quite extraordinary observation. On the questions of the exploratory outcomes, the first of these was total sleep time. And these were the patient-reported total sleep time, which, as we saw from the 3-month study, were remarkably reliable. And what patients reported at 6 months was an additional 20 minutes of sleep. So at 3 months, they had an additional hour of sleep compared with what they'd had before. So they've now got an extra 20 minutes on top of that. Now that was statistically significant. So at 6 months, we've got an extra 20 minutes of sleep. That extra 20 minutes at 9 months was down to 16 minutes. That extra 20 minutes at 1 year was down to 18 minutes. Now, clinically, I don't think they're important differences. Statistically, they were not statistically significant. How do we interpret those findings? Well, I think we have to interpret them conservatively. I personally would not support saying this provides evidence of longer sleeper in the long term. I think the conservative way to interpret those results is to say that there's no evidence of a loss of effect over time. That's by far the better way to report that as an outcome, which is in contrast to benzodiazepines and Z drugs, because we do see loss of effect over time with both of those. On the question of the daytime symptoms the following day, again, they used this questionnaire, but the questionnaire on this occasion needed to have a 20-point difference for it to be considered clinically important. And there's an interesting finding here, which almost makes me smile, because at 6 months, 9 months, and 12 months, the improvement in daytime functioning was statistically significant. So there was a statistically significant improvement in daytime functioning with daridorexant compared with placebo. But at no point did that improvement in functioning reach the 20-point level for clinical importance. They're all around a level of 10. So how do we interpret that finding? Statistically significant, but not clinically important. And again, I think we need to think about it in a conservative way. Again, what we say here is there is no evidence from this of any diminution in effect over time. We are seeing a statistically significant improvement in daytime functioning, but it doesn't actually reach the level of clinically importance, but we don't see any falling off of daytime functioning. That's the way to interpret it. So with daridorexant, we have an effective treatment with a remarkably benign side effect profile, with strong evidence for its use in the short term and the long term, with no evidence of withdrawal effects on cessation of treatment, with no evidence of a loss of effect over time, and for my money, stronger evidence than we have for CBTI.
Remarkable effects. I have read that the cost of daridorexant makes prescribers reluctant to use it. Is that right?
I have heard that said, and it's a very common question, how much does it cost? And because I've been asked that question so many times, I do know how much it costs now. Imagine going to your coffee shop of your choice and asking for a cup of your favorite coffee and how much that's going to cost, between £3 and £4. Daridorexant costs less than half of a cup of coffee per day. So its cost per month is £42. So it's hardly expensive, particularly not when you consider the consequences that insomnia has on people's emotional, mental, and physical well-being.
Helpful to see it in context like that. And so my last question, how should pharmacists respond when someone who is having trouble sleeping asks them for something to help?
The important thing is for pharmacists to establish, as so far as they can, whether this patient has got short-term or long-term insomnia. And there are 5 quite simple, straightforward questions that they can ask to try and determine that. And they're not in any particular order, doesn't matter what order they get asked in. But the first is to ask what the sleep problems are like exactly. Is it difficulty getting to sleep, difficulty staying asleep? The second question is, could there be anything externally that might be affecting your sleep? So shift work, for example, being in a noisy environment, jet lag. So those kind of things. How long has it been going on for? Because if it's been going on for less than 3 months, then they can treat it as short-term insomnia. How often do they have a poor night's sleep? If it's less than 3 times a week, again, that's appropriate for an over-the-counter recommendation. And how do you feel the next day? Because the next day consequences are an important aspect of chronic insomnia. Now, if the patient says, well, I can't get to sleep, I can't stay asleep, there's nothing that's keeping me from getting to sleep that I know of, it's more than 3 times a week, it's been going on for 3 months and I feel awful the next day, that's chronic insomnia, and that either needs a referral or for a prescribing pharmacist, they may consider then prescribing Daridorexant.
John Donoghue, thank you very much for talking to us about this terrifically interesting topic. For more information about John Donoghue's work, please visit the website using the links in the description, and be sure to subscribe for more news, videos, journals, and podcasts. And thanks for watching.